seconds after I start the recording, you can open the meeting, okay?
Okay.
You ready, David?
So good afternoon. Welcome and thank you for joining us today for the meeting of the New York City Health and Hospitals Board of Directors. Today's meeting is officially called to order. Next on the agenda is the adoption of the minutes for the board meeting held November 19th, 2020. Are there any questions, comments, or suggested changes? May I have a motion to adopt the minutes?
So moved.
So moved.
So I'm going to poll each member for their vote. Dr. Calamia,
Yes.
Dave Shoxi, Gerald Cohen.
Yes.
Yeah, and he's representing Hillary Cummings in a voting capacity. Deputy Mayor Melanie Hartzog. Scott French representing Stephen Banks. Helena Arteaga de Landaverde.
Yes.
Barbara Lowe.
Yes.
Robert Nolan. Bob, you there?
Yes.
Sally Hernandez Piñeiro.
Yes.
Rita Wang.
Yes.
And Anita Kawatra.
Yes.
And I also vote yes, so the minutes are adopted. During the executive session, the board received and approved oral and governing body submissions from NYC H&H Bellevue and Kohler Long-Term Care and Rehab Center. The board also received and approved semi-annual governing body reports, written submissions from NYC Health and Hospital of Jacoby and North Central Bronx. VENDEC approvals. Since we began the process of approving contracts prior to VENDEC approvals, there are 15 new items on today's agenda requiring it, of which 5 have VENDEC approvals. There are 5 items from previous board meetings pending VENDEC approval. Since we last met, we have received 2 VENDEC approvals. So we will continue notifying the board as outstanding VENDEC approvals are received. So I'm going to move on to our resolutions. Let me find the file here. Hold on a second. In your agenda. I'm sorry, number.
Okay, I'm sorry, Jose. Dr. Katz is now in the room and we can resume
And
our
it's approving the New York City Health and Hospital effective January 1st as any changes are approved by the board, and further authorizing the appointment of
I think there seems to be a
say that again, I'm sorry.
Jose, I'm sorry, but you're cutting in and out, so I'm going to turn the meeting over to Dr. Katz.
Okay.
Thank you.
Calicia, what number?
Let's go to resolution number 3.
2.
And you can read it.
Okay, approving the New York City Health and Hospital Corporation Annual Board Committee assignments effective January 1, 2021 is set forth in the appendix attached until such time as any changes are approved by the board. And further authorizing the appointment of Frida Wang to be the vice chair of the board until such a time as a change is approved by the board.
Any discussion?
Any discussion? Okay, then all in favor, please say yes.
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 Anyone opposed, please say no. Any abstentions? Okay, very good. It's passed. Thank you.
Number 2.
Okay, number 2.
Dr. Calamia would read it.
Right. Dr. Calamia, could you please read it?
Yeah, so I have this as action item number 1. Is that right? Authorizing the New York City Health and
Yes.
Hospitals Corporation. Thank you. Authorizing New York City Health and Hospitals Corporation, the system, to authorize funding to continue the terms of its current affiliation agreements, with each of one NYU Grossman School of Medicine, NYU, two Icahn School of Medicine at Mount Sinai, and three Physician Affiliate Group of New York PC, PAGNY, each made for the provision of general medical care and behavioral health services with the system facilities served by each of such medical affiliates, and with the cost of each such extension to be an amount not to exceed the amounts indicated below as follows. NYU, with Bellevue Hospital, Gouverneur Healthcare Services, Kohler Rehab and Nursing Care Center, Henry J. Carter, Specialty Hospital and Nursing Facility, Woodhull Medical and Mental Health Center, Cumberland Diagnostic and Treatment Center, for an amount not to exceed $117,253,104. Mount Sinai, Elmhurst Hospital Center, and Queens Medical Center, for an amount not to exceed $83,557,970. And lastly, PAGNY, Lincoln Medical and Mental Health Center, Morrisania Diagnostic and Treatment Center, Segundo Ruiz Belvis Diagnostic and Treatment Center, Jacobi Medical Center, North Central Bronx Hospital, Harlem Hospital Center, Renaissance Healthcare Diagnostic and Treatment Center, Metropolitan Hospital Center, Coney Island Hospital Center, and Kings County Hospital Center, for an amount not to exceed $197,032,971, with the overall total not to exceed $397,844,044 for the period, which includes 5% add-on for enhanced staffing related to an expected COVID-19 patient surge and 10% contingency per affiliate. This resolution is being brought to the entire board for approval.
Thank you, Dr. Calamia, for reading it. And I'll just say broadly, these affiliation agreements are really important
Dr.
to
Katz,
us.
Dr. Katz, I'm gonna recuse myself and same
Okay.
with Dave Shoxey and Gerald Cohen.
Yeah, this is Dr. Cohen. I'm going to recuse myself as well for this discussion and vote. Thanks.
Okay, thank you.
Thank you.
Okay.
Thank you.
Wait, they're not
I'm
out
waiting.
yet.
Okay. These affiliation agreements are really important to us. They are the way we are able to have great physician and other clinical faculty. They empower our teaching programs for our residents. They include research issues. They are complicated and important. We only redo them every 5 years. We had in this year high hopes of making a lot of changes that would help both the affiliates and us. This is not about us alone pursuing things. This is about deepening and improving the relationship on both sides. Of course, the COVID that we had last starting in February and March, and then very bad in April, got our timing off. We came to you and asked for a 6-month extension. We certainly had hoped that by August, September, the COVID risk would have been decreased. Instead, we find ourselves back in a resurgence planning, which we've been doing for the last 2 months, as well as planning on vaccine and other issues. So we have not been able to make as much progress toward completing these agreements as we had hoped. Although I'd like to say, having been personally involved in several of the negotiations, we are making good progress. We don't believe that there's anything that will keep us from closing it, but we also did not want to arbitrarily say, okay, well, the 6 months is over and we're very busy now, so we're just going to sign the agreements because we said we were going to sign it, and we'll take up these other issues in 5 years. That did not seem like the good government approach. And so we believe in the extra 3 months, we will be able to resolve all of the remaining issues in ways that are positive for both us and the affiliates. Before I open it up to questions, I would like John to explain the dollar amounts. Why these particular amounts, John? Where do they come from?
Yeah. Yeah, there's.
Oh, I'm sorry. There's a full presentation.
A couple.
I'm sorry. There are some slides. John, you do it.
Sure, I can
Or Michelle.
start off. The first slide actually walks you through what Dr. Katz actually has just discussed. These are 5-year agreements. The current agreement that is coming to a close was signed in 2015. We came to you on June 25th, 2020, and you granted us a 6-month extension through December 31st, which we are now. Everything else here speaks to the fact that we have been working diligently. We have come across unexpected complications such as a COVID surge, which has required a lot of our planning and strategizing of all of those who are involved in negotiating this agreement, as well as planning for the vaccine and the monoclonal antibody, and everybody around the table is aware of that. We're changing every day, we're moving forward every day. I would like to actually go to slide 4 from here. The next slide, and then the next slide. These are the major buckets of work that we're focused on: contract management, budget and financial issues, as well as medical policy and management. From the contract management, we are establishing a contemporary master agreement form. We are not modifying the previous agreement. We are actually writing de novo a new agreement, which includes improved oversight structure, which did not exist before. From the budget and financial perspective, we're engaging the affiliates to define their workforce so that we can properly establish a budget for the facilities. The workforce is defining who's in the workforce, how much time they spend in the facility, what the expectations are in the facility. Based on the workforce development definitions and expectations, the budget is set from that, and this is the first time that has been done as well. In addition, making sure that there's alignment between the physician workforce and the strategic plan of the system. At this point, I'd like to go to the next slide and pass it over to Mr. Ulberg, our CFO.
Good afternoon. When we were last before you, and I'll kind of step you through how this chart works. When we were last before you, you granted us a 6-month extension for the period 7/1/20 through 12/31/20 for a total, we lay it out there by affiliate, but for a total of $722 million. And included within that was a 10% contingency. For this request for 3 months, right, we've laid out the totals at the bottom with the new added 5% COVID contingency, because we're not quite sure, as we're approaching the second wave, whether there'll be some additional cost pressure. So the amount that's in the resolution is a total of $397 million. If you were to do the math between the 6-month extension and the 3-month, right, and divide that, to get a per month amount, the numbers don't exactly line up, because during the 6-month extension period, there were numerous requests that are made by the affiliates, right, to make certain, salary adjustments. Michelle gets requests for the affiliates, to increase salaries, for a particular specialty at a particular affiliate. We're always trying to rebalance salaries across the system for greater equity. And when we make those decisions, right, we benchmark that. But the reason why, if you were to do the math, it doesn't exactly line up is because of those sorts of adjustments that happen between the 6-month and this 3-month extension period. And then down below, we're just giving you the full, breadth of numbers from going all the way back from FY16 to FY20, just to show you all the numbers that are involved in the affiliate arrangement. Any questions?
So we'll go to the next slide, please.
Should we just, are you guys finished? Do you want us to do questions now?
Yeah. So there's just the last page that summarizes everything that we've just presented to you. We're seeking authorization to continue operating under the existing affiliate agreements while renewal negotiations, authorizations, and final execution of the agreements are completed, with the cost of continued operations not to exceed as follows: Mount Sinai, $83.5 million, NYU, $117.2 million, Cagney, 197 million, not to exceed extension budget authorization total of $397,844,045. The total contract value of $7,872,291,654. And then itemization of what you approved, what the contract was valued at 2015 through 2020, 6.7 billion. The 6-month extension in June 2020 of 722.6 million, and the current extension request of 397.8 million. That is our request, and we're ready to answer your questions.
Questions? Please go ahead, Frida.
Thank you. And I appreciate all of the work you guys are doing. And Mitch, thank you for your comments. I know the team is working really hard on getting this done. And I agree wholeheartedly that better to get it done right than rush to a deadline. So I think that this is great. The principles you've laid out are good, and they ensure alignment and accountability. So thank you. But John, the explanation of the costs were helpful. I think that what does answer some of the question I had, but I wanted to try to understand a little bit the table. So on the bottom of the 5-year contract period, that lays out the request total. Is that what was actually spent under the 5 years, or was that?
Yes, it would be pretty close to the amount that was actually spent. And I can report, for the 6-month extension, the 722, we're underspending on that amount. I think if you work out the math, it's about 126 per month, and we're spending somewhere around 120. So not the full amount that you authorized.
Okay, great. And just one question on the contingency. So I think we saw somewhere in the materials that the 10% contingency is what we expect is necessary, but I noted that the original contract had a 25% contingency. But you're comfortable with just the 10? Is that?
We're comfortable with the 10. And again, we did add the extra 5% because we're not quite sure what lays ahead of us, on the COVID contingency. I think between the two, we should be fine here. Okay.
And then just for that COVID contingency, that's really just additional contingency, or there's not some tracking of our costs related to COVID for our affiliate contracts, or is there?
Yes, we're trying to do that. We're trying to track the additional hours, right, that physicians will work related to COVID. We did that for the sessionals, and we actually have an agreement with each of the affiliates that we signed during the first wave to help us track those dollars, right? Because we would ultimately want to build or try to claim FEMA, right, for the additional work. That's our rationale. Hopefully that will hold with FEMA, but that's what we're doing.
Okay. All right. Well, that is helpful. I think there was another. So so I understand the authorization request, it's not for a time certain. It's not, we anticipate this will take us for 3 months, and it will take approximately 3 more months to get, up to 3 more months to get the contracts finalized. But let's say that time frame expands a little bit. I know it's a lot of work, and there's still COVID in front of us. How is it that you track the dollars, and once we get to say 397 million, you would have to come back and get a new approval? Is that sort of how this authorization would work? Okay.
That's my understanding of how we set it up. Yes.
All right. It might be helpful just monthly for us to make sure we know where you are on that, so we have a sense in terms of both where the contracts negotiations are going and how we're doing on the spending. So.
Sure.
Yeah, Frida, if it's helpful, the reason we had a formal deadline on the other one, the first extension, this is Andy, and didn't have one on this one, is that we got formal extensions or sought them with the affiliates for 6 months. So we signed sort of new agreements. In this case, we're using our month-to-month authority. So there isn't a formal contractual deadline. And if the money lasts a little bit longer and it's needed, hopefully, doesn't happen. This has to get us to we perceive that this will probably need to get us to final execution, which means the last signature of the last person across these 4 parties, and sometimes that adds some time.
Right. And Andy, on that point, then, if we don't have a formal contract extension, does the contract itself anticipate going to a month to month? I mean, how do we keep the affiliates on contract if there's no actual agreement?
Yes, the contract itself has a month-to-month provision and a minimum of a 1-year termination clause. So, and there is a discussed understanding among us as well that we are deep in negotiations to continue this. So there is no legal opportunity or relational opportunity to walk away during this period.
Got it. Great. On the point of contract term, I know, Mitch, these contracts are generally 5 years or have been 5 years. And by the time realistically this is executed, we'll be down to close to 4, right? 4.5 years. Is there any benefit to considering a different contract term? Or is that?
Are you thinking a longer term or are you thinking a shorter term?
Well, no, going to say 5, just having it be
5 years from the date of signing.
right. I mean, was there, I guess the thought.
Seems
Go
like
ahead.
an attractive idea.
I think there's some benefit and actually some requests from the affiliates to keep the years on a fiscal year basis. That's kind of how budgets are set, et cetera. And so there was a lot of interest on both sides to keep them at fiscal year starts and fiscal year ends whenever possible.
Right, but if we take this to March 31, 2021, right, for execution, let's just say it's 3 months, then you're almost closer to June 30, 26 as opposed to June 30, 25.
We
So
certainly can do that.
But anyway, it's
Let's
just a
discuss
thought.
it, Frida, with our partners.
Yep.
Thank you.
I think that was it. So thank you very much.
Thank you, Frida. Other board members who have questions, please. Okay, then if not, I'm going to take a poll vote so that we're sure we have everybody covered. Ms. Lowe?
Yes.
Frida?
Yes.
Anita?
Yes.
Helen?
Yes.
Helen, are you there?
I said yes.
Thank you. Bob Nolan? Bob? Are you there?
Yes.
Okay, thank you. Sally?
So just, this is a vote on a 3-month extension, and then when we have the final 5-year, whatever 5 years it is, contract, then it'll come back to the board on a new resolution for that, right?
That's correct, Sally.
Okay, yes, then.
Thank you. Scott French?
Yes.
Dr. Calamia?
Yes.
Dr. Calamia?
Yeah, that was a yes.
Okay, thank you. Deputy Mayor Herzog? Okay. Okay. All right. And myself, yes. Okay. All right. We're all set.
Okay.
Okay. We need to get back Jose. Okay, good.
So we can start the,
Okay, shall I read it since Penny is not able to participate today?
yes.
Okay, Resolution 4 is authorizing the New York City Health and Hospitals Corporation to execute a contract with Rising Sun Construction LLC for an amount not to exceed $12,425,781.30 for construction services necessary for the construction of the exterior facade rehabilitation at Health and Hospitals Harlem Hospital Center with a 15% contingency of $1,866,000 $453 for unexpected changes in scope, yielding a total authorized expenditure of $14,292,234. SVP Flaherty, you're going to start?
Yes, thank you, Dr. Katz. I love your mask, Harlem Strong, well represented. I'm here actually virtually. Ms. Carrington, our CEO of Harlem, is also on. I'm here with our AVP of Design and Construction, Oscar Gonzalez. So we could go to the first slide, and I think Ebony is on the line, ready to talk to the critical need of this infrastructure work to happen at Harlem Hospital and how it will impact her and her hospital. Ebony?
Yes, good afternoon, and thank you, Christine. Good afternoon to all the members of the board and my colleagues. Thank you for the opportunity to share with you really our burning platform around the need to do some facade renovations and to address the exterior of both our Martin Luther King Pavilion as well as our Kuntz Pavilion. They were constructed in 1969 and 1950 respectively. We've had a significant amount of community complaints around safety and the general aesthetic look of these buildings. It requires us to move into this contract, and we would ask for your favorable vote so that we would be able to actually remediate some significant conditions on the exterior of these two buildings. We have noted an uptick of complaints from our community partners, and it also does pose not only some lighting, but some safety and security risks. So we ask that in addition to what you will see in the pictures, that you appreciate that our entire community perception and being good neighbors rests on our ability to actually make our campus as aesthetically pleasing as possible. So with that being said, we know that there are several windows, there's broken glass, there's some repointing of the bricks that's required, and Ms. Flaherty will take you through the logistics of the project as well as the pricing, but we would ask for your favorable review of our project.
Thanks so much, Ebony. We're really trying to expedite this type of work throughout our system. One of my first resolutions was one with Sheldon McLeod at King's, where the sidewalk shed had been up to protect the public for many, many years, over a decade. So in this case, going to slide 2, which will show you our second building that we're working to further enhance and protect. This is really to comply with the facade safety and inspection program that we have in place and maintain a safe environment for our staff, patients, and the public. The complete exterior facade reconstruction will remove all of our unsafe conditions at both of these important buildings to the hospital. This construction project was designed and the construction documents went out to public bid. Rising Sun was the lowest responsible bidder out of 16 bidders. The firm has a 31% subcontractor utilization plan. The firms indicated in the utilization plan are listed there, as well as their level of participation in the $12 million contract. The MWBE amount is $3.8 million. And this contractor is a new contractor to Health and Hospitals. It's also a new contractor to the City of New York. However, they do have experience working for both Postal Services and the MTA. We reached out to them and we did receive favorable recommendations based on their level of service to those two entities. If approved, we would be working to send this contract to the controller. It's a city-funded project, and we expect the construction to complete in 2022. The next slide shows you a total project budget for the project, covering all of the ancillary contracts that support this construction contract, from design fees, construction management services, our contingencies, as well as an allowance for abatement services should we come upon additional unforeseen conditions. So the total project budget here is $16.5 million, which is integrated into the resolution language, which is on the final slide. With that, I think we'd be ready to take any specific questions by any members of the board. Thank you so much for your time.
Jose, you're going to take back sharing.
Okay, I will. Any questions from board members on this resolution?
Christine, this is Helen. I'm assuming you already have to do this, or you and Ebony will do it once the project gets approved. But it's like talking to the community boards that this is going to happen, and the timetable, because if we're going to take parking spots, or Are we
Yes.
gonna block some of the streets? Because I know sometimes communities can be a little sensitive. And I know where Harlem is at, it's a very busy street.
Yes, I'll take that question, Christine, if I may. We not only have monthly community advisory board meetings, but we have, in essence, like a patient and family advisory council that we also work with. So we have strong communications plans because we have several construction projects actually happening at Harlem Hospital. So our cadence of communication and our template that we use allows for very free-flowing information. And we also have tight connections with, as I mentioned, some of the community the CBOs. And so the tenants associations, we work in collaboration with the school, which is directly impacted by some of this construction. And they have all been made aware that we are seeking this funding, but they have been really the ones who have shared with us their displeasure with the scaffolding. And so I will be very excited to be able to go back and share with them the news should this be favorably voted upon.
Additionally, I would just add this type of construction, once they've mobilized the materials and the workforce, it will largely be within the footprint of the sidewalk shed that is in place. So it's really not something that would take up in long-term major roadway areas. It's really going to be within the footprint of that sidewalk shed that nobody wants to see, but is really truly protecting all of the people going in and out and in the community.
Thank you. Any other questions from board members? Okay, so let me then move to a vote at Dr. Katz,
Yes.
Dr. Calamia,
Yes.
Dr. Shuxi, Gerald Cohen, Dr. Cohen, Scott
Yes.
French. Thank you,
Yes.
Dr. Cohen. Scott French,
Yes.
Elena Arteaga Landaverde, Helen,
Yes.
Barbara Lowe,
Yes.
Robert Nolan,
Yes.
Sally Hernandez Piñero,
Yes.
Frida Wang,
Yes.
Anita Kawatra,
Yes.
and I also vote yes. So resolution approved. Let me move to the next one. Thank you so much.
Thank you.
The next one is, give me 1 second. It's number 5, authorizing New York City Health and Hospitals Corporation, the system, to execute a 3-year requirements contracts with each of G Systems Inc., G Systems, Coranet, and Mason Technologies for information technology cabling services with the system, with 2 one-year options to renew such contracts with each firm, and with a total cost of all 3 contracts over their full potential 5-year terms, not to exceed $75.5 million. This was presented to the Joint Capital and IT Committees on December 3rd. So let's move to a presentation.
Good afternoon. I'm Kim Mendez. I am the Chief Information Officer for New York City Health and Hospitals. Just as a general introduction, IT Services is looking forward to this proposal for a structured cabling agreement, which will help support us with more efficiency as well as responsiveness to our project needs. Jeff Lutz, our Chief Technology Officer, will present the report.
Good afternoon, and thank you for your time this afternoon. So we are here to seek approval to enter into 3 contracts with 3 vendors to provide structured cabling, which is essentially how we provide the connectivity between our end user devices, so the PCs, printers, and as well as wireless services, as well as our voice over IP, which is our phone system services, to those end user devices and allowing them to connect back into our system to the data centers as well. And so these contracts, it would be not to exceed $75.5 million. They are a 3-year contract with 2 one-year renewal options, so for a total of 5 years. Upon award, going forward, any future large projects would be awarded based on mini bids that would be used or issued looking for cost as well as the availability to meet timelines. Smaller projects, which includes moves, adds, and changes, will be mostly determined by scope, would be at the discretion within Health and Hospitals. to order. Next slide, please. So the procurement, we went through. The evaluation committee was made up of members of both EITS and our partners in OFD. The criteria was based on their experience, their technical proposals, costs, and their MWBE utilization. And for us to truly appreciate the costs, what we did was we took similar projects that we had recently, and we overlaid the costs and made judgments based on how those items fleshed out. Next slide, please. So the procurement was issued in September of this year. We actually sent the RFP out directly to 4 vendors, posted also on City Record. We had a pre-proposal conference call. Based on the conference call, we received 7 proposals. 3 were from certified MWBEs. The rest agreed to do the 30% utilization. We made a selection in October. The 3 that were selected, the highest scoring, included G Systems, who will meet the MWBE 30% utilization, Coronet, and Mason, who are both MWBE. Next slide, please. So this slide here shows our estimated spending over the next, the duration of the contract over the next 5 years. The expense side is based on prior years and contracts and use that we've had there. Capital is supported by currently approved projects, such as our network refresh, biomed projects. Capital, those are new needs. Those are anticipated projects based on history. We did kind of a rolling average of what we had seen in the past. These would all be dependent on future approvals for funding associated with them. Below, you'll see our historical spend, which is how we came up with both the expense and, again, the previous capital. So as you see, previously or currently, we leverage a lot of G Systems and Mason. Both of these vendors have been excellent vendors for us, supporting us. We would have not have made it through our Epic or our point-click care projects, as well as COVID projects, if it was not for these 2 vendors. G Systems does meet the MWBE utilization by purchasing all of their materials needed for the job through a certified MWBE, Network Building Technologies. And again, as I mentioned before, Mason is a certified MWBE. Coronet is a MWBE partner that we've used through other services, but we have not used them in this capacity, and we look forward to working with them. They have a lot of good experience previously holding the city contract for a similar, for these similar services. Next slide, please. So again, in summary, today we looked for, ask for your approval to enter into a contract for G Systems, Coronet, and Mason, again for 3 years with 2 one-year renewal options. The estimate not to exceed would be for $75.5 million. Payments would be based on the work order and termination for convenience. MWBEs, our Coronet and Mason are both fully MWBE, and G Systems will meet the 30%. At this time, I'm open for any questions.
Thank you so much. Any questions from board members?
I just would like to know, physically, where is this cabling going?
So good question. So the cabling is throughout our enterprise. It happens within the hospitals as well as within our office locations. And then such as even our new clinics, the centers of excellence and everything, that each of those areas where it requires a computer, this is the cabling that connects it back to the network cabling that connects it back to our systems, the data centers.
Oh, good. Okay, thank you.
Thank you. Any other questions? Okay, so let me then take a vote. Thank you so much. So Dr. Katz?
Yes.
Dr. Calamina?
Yes.
Dr. Cohen?
Yes.
Scott French?
Yes.
Helen Arteaga Landaverde?
Yes.
Barbara Lowe,
Yes.
Robert Nolan,
Yes.
Sally Hernandez Piñero,
Yes.
Rita Wang,
Yes.
Anita Kawatra,
Yes.
and Jose Pagan, yes, also. So the resolution has been approved. Let's move to the next one. I think, Rita, you have that one.
Um, authorizing New York City Health and Hospitals Corporation to sign 9-month requirements contracts with the following 8 firms, together the vendors: Rapid Reliable Testing LLC, Ambulaz, Rapid, sorry, I need to put my glasses on. Somos Healthcare Providers, Inc., doing business as Somos Community Care. Somos BioReference Laboratories, Inc., BRL, Fulgent Genetics, Fulgent, North Shore Medical Labs, Inc., NSL, MedRite LLC, MedRite, Premier Assist, Premier, Mako Medical Laboratories LLC, Mako, for COVID-19 testing services in schools operated by the New York City Department of Education, DOE, and at mobile testing sites within the system, holding 1 3-month option to extend each contract, and with the total cost of all 8 contracts over their full potential 1-year terms not to exceed $189,708,960. And this was discussed and approved at Finance Committee last week to bring before the board. And I think, thank you.
Well, thank you for the opportunity to come and present our resolution today. So I'm going to give an overview of the resolution itself here, and then I'm going to turn to Chris Keeley to go into the details behind the resolution. So 2 of the problems we're trying to solve here are, one of the most effective tools we've had against the fight towards COVID is our ability to do massive testing across New York City. We, in one day before Thanksgiving, did more than 95,000 tests of New Yorkers in a single day. And in that week, we did more than 500,000 tests. What we want to do here is put together the next version or iteration, if you will, of our testing strategy, which is our ability to do mobile testing. One of the things we've learned well is that the best way to get people to get tested is to really bring testing to where they are, bring it to every community in New York City equitably, and then then we've seen that people really do come out for testing because New Yorkers really want to keep our city safe. The other thing that's very important is we've been the only big city in the country that's been able to open our schools. One of the key ways that we've been able to do that is to have an aggressive testing scheme regime in our schools to ensure that we know exactly what's going on with the virus, and to make sure that our students and our teachers are always safe. So what we're going to present today is our strategy for continuing to do massive testing across New York City, which has been, again, a cornerstone of how we've gotten the control of the virus that we have, and our strategy for continuing to do testing in our schools to allow us to continue to offer in-person education to New York City students, which we're very proud of.
Hi, good afternoon. My name's Chris Keeley. I'm in the Office of Ambulatory Care and Chief Operating Officer for the Test and Trace Corps. Really what we're looking to address, as Dr. Long mentioned, is we want to be able to be prepared for the months ahead, not knowing what's coming. There's 2 particular areas that we're looking to focus on: school testing and community testing through mobile resources that we can deploy really anywhere in the city on short notice. You can see even on the last slide, we've changed, even in the last few weeks, the parameters around testing in the schools have changed from monthly testing to weekly testing, that grades 6 through 12 now are not open. So this is a constantly evolving thing. And so what we wanted to be able to do was go to market, identify some qualified vendors, bring them through so that we can start to build the processes with them should we need to engage them, not knowing what's coming. And so what we have established here is some core parameters around turnaround time, where we won't be paying for results that are provided after 48 hours. For the DOE testing, in-school testing, we're looking to have vendors that can deploy 20 or more teams, mobile units that can deploy, vendors that can deploy at least 8 mobile units. Mobile units you can think of as, during good weather, during the summer, you can think about that as a sort of Amazon delivery truck that comes up and parks on the street, and then you put up a pop-up tent. You could put up a canopy tent or two, and you have a team there right there on the sidewalk, able to register staff, register patients, swab them, and then get that specimen off to the lab. Important to note, that's the model that we've been using. We'll continue to use in some form. What we're going to be doing in this, these vendors are going to be doing this. These patients will not be Health and Hospitals patients. These will be patients of those entities which we're hiring to do this work. Similarly, on the DOE side, those students, those staff that have consented to do this testing, they will be the patients of those partners that we're working with through this. The general fee structure is one of two options that we ask them to propose, either a per team cost structure or a per test cost structure. Generally on the per test cost structure, we're looking in the range of $75 per test. And on the team, on a per team basis, generally we're in the range of a few $1,000s per day for those teams. And really what we're looking to be able to do, as it says in a number of different ways in this presentation, is to be able to quickly expand capacity, not knowing what's going to be coming a week or a month from now. We want to have a bench of capacity that we can tap into. On the next slide, we can take a look. Those minimum criteria, again, about being able to work quickly, being able to scale up. On our substantive criteria, we looked at cost and relevant experience as two major drivers, as well as ability to scale. Data management. Data management is particularly important on the DOE side of the work for the in-school testing, because what happens here is a positive test that comes back from the DOE testing comes into the Department of Education Situation Room, and then Test and Trace Corps works with the Department of Education and other agency partners to conduct an investigation into what's going on at the school, minimizing further exposure, closing down perhaps a classroom, maybe even an entire school, maybe for a few days, maybe for up to 2 weeks. So having that data management is really core on the DOE side in particular, so that that data can come in a timely and reliable way, get into that situation room, and we can conduct those investigations. Community and language expertise and MWBE were also substantive criteria. On the evaluation committee, we had individuals from a clinical, operational, finance perspective, and a host of others that have been involved in the program in a variety of ways. Finally, we did this in a relatively expedited fashion because, as you all know, in the current COVID space, we need to be able to move quickly. We didn't know how quick things were going to be evolving on the DOE side. So we had an expedited process where the CRC approved a request to solicit proposals in early November. Within about 10 days, we had gotten 16 vendors responding. None of those vendors submitted, no MWBE firms submitted a proposal. 7 of the firms that we selected are able to do both DOE testing and mobile testing, with the 8th being able to do just DOE testing. We've reached out for all 8 that we wish to contract with. We've reached out for references. The references have been strong on both the DOE and the mobile unit side. You'll see here on the slides that we've received MWBE plans from each of the vendors, including one with certification pending. Next slide. What we're looking at here, again, the contract is based on number of tests or teams. There's no minimum commitment. This is a requirements contract. Again, we don't know necessarily what to expect. We just want to have the capacity available to dip into it should we need. The funding on this is covered by the Test and Trace MOU with the City of New York. And the request is to approve this for the 8 vendors mentioned to perform testing for DOE schools or in the mobile units for a period of not to exceed 12 months for an amount not to exceed $189.7 million. So thank you. We ask for your support in this, and we'd be happy to answer any questions.
Thank you so much for the presentation. Any questions from board members?
I'd like to have a better sense of your 8 vendors. Do you know how many were in what I'll call phase 1, the work that you're currently doing?
So the work that's been underway, currently 3 of the 8 are currently partnering with us on in-school testing. Those 3 are Somos BioReference, listed here on screen as BRL, and Fulgent. Apologies for the typo there. That should say Fulgent, not Flugent.
I think on the committee presentation, we noted there was a notation that, and I've forgotten the numbers, a certain amount of money, a certain dollar amount of expenses had been incurred by H&H, and less than that, say half of that, had been reimbursed by the city. Would you have any sense of how much money was paid to the 3 vendors and how much is still owing?
Sure. So I can speak to this on a high level. Oh, I apologize. Go ahead.
No, you can get me that information whenever you have it. I just am curious, just, I guess, have a concern that vendors not be sort of out of pocket as they're entering into yet a more expansive role. And if you say that, you know, city payment is imminent, then that's fine. But
Yeah,
that, yes, go ahead.
Yeah, I can briefly speak to that, and I'm not sure if Krista Olson from Finance is on, if she wants to add anything. At the time that we made these slides a few days ago, it had been $4.1 million had been invoiced at that time. Since then, a few more invoices have come in, and what we're looking at now is actually closer to $9 million that has been invoiced to us for that work from those 3 vendors for the work for in-school testing. I'm not sure in front of me how much we've actually paid out, but all of this work under this contract would fall under that MOU with the city.
Right.
And if,
I'm
not sure
the timing of payment is critical. I mean, I know that they'll get reimbursed, but it's important that the payment be timely.
Can
That was-
Krista answer? Krista, can you answer?
I can. So we've paid out about $8 million of the amount that's been invoiced. We are pending receipt of a few additional invoices, but as we get them, we do try to pay timely and totally understand your concern. Yes, I believe there's a few more, like probably about $3 more million of invoices that we are pending receipt of before we can pay.
And this is not eligible for reimbursement by FEMA, is it?
We have several federal funding sources that are supporting this work. FEMA is one of them. The other is a CDC grant, and we work closely with OMB to determine which is the right funding source and to submit the claim.
But Krista, that FEMA dollars aren't H&H FEMA dollars, or it's a different FEMA bucket. Is that correct?
The city is submitting the claims on for test and trace. That's correct.
Okay.
Thank you. Any other questions?
Jose, can I just ask some questions? Because I think it's important, since Fenny is not here and he did express some concerns at committee. So I know it was an incredibly compressed time frame, Chris and Keith and Ted. So I appreciate the team and the vendors getting the MWBE utilization plans formalized, because I know at Finance Committee we didn't have that. So I'm glad to see 6 of the 8 have plans that will meet our targets. But of the other 2, can you just give a little bit of context for why they're below the target?
Sure. Can you hear me?
Yes.
Great. So both BioReference and Fulgent are self-performing that additional amount, the delta between 30 and their plan. So there's no opportunity for subcontracting, and without an opportunity for subcontracting, the policy and, both state, city, and our draft version allows for business models in that case to then, say, okay, if you don't have any active subcontracting and you're self-performing with your employees, then, there's really no goal to be set that high as 30%. So it's really, they're meeting the goal. The goal is adjusted downward here.
I see. And how are they, if they're self-performing, can you just give an example of how they'd be meeting the goal?
Sure. So the other vendors aren't self-performing to the extent that these 2 vendors are self-performing with their vendors, with their employees rather. So that 10% of subcontracted spend represents all of the temp staff that BioReference is using locally, and same thing with Fulgent.
I see.
Does that answer the question?
Okay. Yes, thank you. And then on the, just in terms of, our sort of 30% identified target, I guess I'll say, this approval doesn't require you to use any of these particular vendors in any particular level, at any particular level. So in some regard, there can be some, we could look at the overall contract and say, or the overall spend for these contracts and say, we did, keep track of how we do on our target, right? And try to get to the 30% at least.
Yeah, absolutely. If the work is evenly distributed, you have an average MWBE utilization of 34%.
If it's evenly distributed, it would be 34. And that's because we have one that's a full MBE, correct? Is that why you can get to 34? All right, okay. All right.
Excluding that vendor, just FYI, it's 25%. So it's still a pretty good number.
Right. Okay. So I think that I think it would be good to just be able to report on that and make sure we're keeping track of that.
Agreed.
Thank you, Jose.
Thank you. Thank you. Thank you, Keith and Frida. Any other questions from board members? Okay, so let me move to a vote. Dr. Katz?
Yes.
Dr. Calamia?
Yes.
Dr. Easterling, representing Dr. Shoksi?
Yes.
Dr. Cohen?
Yes.
Scott Finch?
Yes.
Helen Arteaga Landaverde? Helen?
Yes.
Barbara Lowe?
Yes.
Thank you. Robert Nolan?
Yes.
Sally Hernandez Piñero? Sally? Rita Wang?
Yes.
Anita Kawatra?
Yes.
Sally, are you trying to say something?
Sally.
I just wanted to acknowledge how proud everyone is of the work that's being done. You know, we're clearly the national leaders in this space, and you guys are just doing a terrific job. Yes.
I second that. Thank you, Sally. Frida, you already voted, right? So, and Anita?
Yes.
Thank you so much. And myself, yes. So resolution is approved. Yeah, thank you so much for all the work you do, our test and trace team, and Ted, Chris. It's amazing that how we have gone from not having to having this infrastructure in place, and we're very proud of the work you do. Let's move on to, let's see.
Thank you.
I'm a little bit lost here. The President's report, Dr. Katz.
Well, thank you, Jose. And maybe, again, I don't like to read the report. You have the report. I think one comment in continuity with that last presentation was how many people have told me how much better it is to test for COVID in the public sector than in their experiences in the private sector. And as someone who's spent his whole life working in the public sector, trying to prove that we can do as good a job as the private sector, it's been very fulfilling to see that people now recognize they go to our testing center, they're treated rapidly. A lot of the centers are slow because they are focused on making money by creating wellness visits so that they can bill the insurance for a whole wellness visit, when really what the person wants is a test. And so once again, because we see ourselves as mission driven, not as profit driven, we're able to provide a service that actually is responsive to what people need, to turn it around quickly. I'm very proud of that. It is, as you realize from your involvement with us and your reading of the newspaper. It is a difficult time. We are increasing in our patient load. I think today we're at 240 inpatients with COVID and about 80 in the ICU. That is, very small in some ways compared to the almost 4,000 people we took care of last April in a moment in time. But it's still beginning to cause some strain on the system, in part because in the first round, people were so frightened by COVID that they stopped going to the hospital for non-COVID issues, which was by no means a good thing. I think we've demonstrated that we can take care of people safely who do not have COVID. People are continuing to come for non-COVID issues as is appropriate. And what that means is that we're running at high volumes. Still, we are only at about 65% of capacity of the ICU, 65% capacity of the wards. Yet we're doing already level setting. And I want to use that as an example of the things that we've learned from the first wave. In the first wave, we didn't begin to do level setting until hospitals were full. And when we did level setting, we moved patients who were in the emergency room and therefore by definition were unstable, because those were the patients who we didn't have a room for because we were full. So it was all sort of self-fulfilling. What we're doing now is we're making sure that all the hospitals have room. And we're doing that by moving stable patients, not sick patients. So we're moving a lot of non-COVID patients and we're moving COVID patients who are stable so that at all times we have enough room so that anybody coming into the emergency room at any of our hospitals can safely go up to a bed that is empty and well staffed. We've been successful at obtaining enough registry staff so that we still are at stage A of the plan. Stage B is where we go to canceling all our elective surgeries and going our outpatient areas into full virtual visits so that we can pull staff from the outpatient areas to support the hospitals. We're not there yet at any of our hospitals. We're still safely at A, and in part because of the success of the test and trace. While there is growth, as you heard from others, the growth is linear. It's not the exponential, it's not the 12 people needing to be intubated in a 2-hour period of time at Elmhurst that we experienced at the end of March. So we've been able to handle the load. We are gratified that patients are doing much better. We're gratified that we know better how to care for them with the use of steroids and remdesivir and better positioning, using ventilators less that are invasive, using more non-invasive ventilators. The mortality rates are way down compared to the first wave, but we are anticipating that at least for the next 2 to 3 weeks, things will worsen. Once the curves begin to increase, it's in any kind of infectious epidemic, the more people who are infected, the more people who can become infected. There's no other way that this kind of infectious disease epidemiology works. So if you're on the rise, you will continue to be on the rise unless there is some change in circumstance. But because we're able to test and quarantine people rapidly, we think that we can keep this at linear growth, not at the exponential growth. And also that the vast majority of patients presenting are not presenting in respiratory arrest the way they did the first time, but they are in general younger because we're doing a better job of protecting older people and nursing home patients. And so they are doing way better. Staff are doing very well, I think. There is a feeling of greater mastery and competence this time, right? We know what we're up against. We've been through this before. Now it's coming at us at a more manageable rate. So the good part is the feeling of improvement, right? We've learned something and we're able to do it better. The bad part is that there is among some of our staff a post-traumatic stress aspect to this of, where, people are being triggered by the coming of new very sick patients and remembering how it felt to be in the hospital in March and April. Many people had very difficult experiences of that. Many people felt that they weren't able to provide the care that they most wanted to. People have bad memories of patients dying quickly. So, we want to keep everybody's spirit up. We want to keep the staffing at a level that prevents people from feeling overwhelmed. We think we can handle where the growth. We would expect that over the next 2 weeks, there will be about twice as many patients as there are now. We think we can handle that. We've certainly handled more than that in the past, but we have this time a different goal. Last time in March and April, really the goal was make sure that every healthcare worker has protective equipment, make sure that there are enough ventilators for every patient who needs it, make sure that every patient has a doctor and a nurse. This time our goal is maintain the same standard of care that we would under normal circumstances. So that's a harder goal because that assumes maintaining normal staffing and not requiring that doctors and nurses take care of a much larger number of patients than is ideal. We had no choice but to do that the first round because it came and hit us so fast and so hard and people were so sick. But this time around we are, I can say today that everybody of the patients that we have, we're on normal ratios of nurses to patients, normal ratios of doctors to patients. It is still providing care in an ideal way, not at an emergency way. And we're hoping to maintain that throughout this second wave. So, we appreciate, many of you have expressed your support to our staff, to the nurses and the doctors and the respiratory therapists, physician assistants, all of the people who are working so hard, and we really appreciate that. It means a tremendous amount to people in the field to know that their board cares about them and understands what they're going through. So thank you, Mr. Chair.
Thank you, Dr. Katz. Any questions from board members for Dr. Katz?
Mitch, could I just ask, as far as the vaccines, obviously there's so much, I guess at this point, uncertainty in a lot of these issues, but do we have a plan in place as far as, the sequence of who will be receiving first, how it'll be done, who'll be doing it, where it'll be done? Are those things fairly well worked?
We do, Dr. Calamia, to the extent that we have the detail. We still, for example, do not have detail on exactly how many doses we will receive. We still don't have final sign-off from the state on exactly how much detail they're going to provide. So, for example, everybody is clear that the first priority is to immunize the healthcare workers and people who are living and working in skilled nursing facilities. But in healthcare workers, on the first receipt of vaccine, there will not be enough for all the healthcare workers in health and hospitals. So then there needs to be a second level prioritization. The state hasn't specified. They may or may not specify. We, among ourselves, feel strongly that among healthcare workers, you would vaccinate the people at greatest risk for exposure from the virus, which means those people in week one who are performing procedures that aerosolize the virus. That would be anyone, any ICU nurse with patients on a ventilator, respiratory therapists, anesthesiologists, ICU doctors, and emergency room doctors and nurses, because they're the people who are handling the intubated COVID patients, and that's how the virus gets aerosolized, and that's a much higher risk, and that we would, move down through by risk groups, always focused on in each tier who is next at highest risk. Whether the state will promulgate a guideline like that, whether it will be something slightly different, or whether they'll allow each hospital to make their own determination, that is not known, nor again exactly how many doses we will receive.
Yeah, I truly appreciate that. And being cynical as I tend to be sometimes, I suspect we may end up having to kind of do these things ourselves. And I just would hope we have some sort of contingencies for each of those possibilities: number of doses, sequence of people, how we distribute it to them, how we communicate to them, and all that. So I know this is a yeoman task, but he's done such amazing work already, and I imagine this one's just another one of those many challenges that we'll be facing. But anyway, I appreciate that info.
Thank you.
Thank you, Dr. Calamar. Any other questions?
Yeah, Jose, it's Bob Nolan. Can I ask a question?
Right.
Mitch, we all know that our doctors and nurses have been exhausted for periods of time since the pandemic began back in March into April. Can you tell me, is there any downtime that's built into especially our nurses' schedules between their rotations that gives them a chance to rest, or are they going 5 or 6 days a week?
It's highly variable, Bob. I mean, we're not in a mandatory overtime position. So there's nobody who's being mandatorily made to do more hours than their regular work shift. At times, they may be asked to stay later if somebody is sick and can't come in and there's a patient, so that nobody is abandoned. But I think your overall point is true. People are tired. Of interest, there's not as much desire for vacation as you might think, because nobody can go anywhere and nobody can go see their families. So the one sort of strange thing is that, it's not as if anybody is thinking that they're going off for a 2-week vacation, right? There's nowhere to go to and you can't see anyone. So we are concerned about the holidays. Typically, the holidays are a time when there are more vacation requests. What we'll do is try to make sure that everybody, has some days that are off. But our primary responsibility will be to care for our patients. We're trying to sort of frame this for people as it's the last push, right? And that we hope that we push through this, we vaccinate people, the world returns to normal in March and April, and everybody takes themselves for a wonderful vacation when they can.
Well, we'll all be happy to join you, Mitch. Thank you very much.
Yeah, thank you.
Yeah, we'll join you, Mitch. Any
Well,
other
we'll get
questions?
a large hotel room.
Second.
I don't know if that would be such a good vacation for Mitch. I joined him.
Any other questions from board members to Dr. Katz? Okay, well, thank you so much for your report, Dr. Katz. And I want to move on to, let's see, Deb Brown, you're with us, right?
I am. Hi, everyone.
Yeah, give us go ahead.
All right, real quick, thank you. So as you know, in a year that is not like any other year, we still did continue to have our annual public meetings. Up there is a calendar. We did, of course, do them remotely. Many of you participated, and thank you for that. Dr. Katz, of course, gave an overview and gave everyone an opportunity to make some statements. Next slide, please. So what we've done is compile all of the information from those annual public meetings, and then my outstanding team tracked down a response for every one of them, working with the individual facilities and or working with public documents. It is quite an extensive deck. We're not going to go through it tonight, but I want you to note that URL in light blue. It is there and it is available, and of course we're happy to answer any questions. And as you'll see, each of the issues is identified, as well as the facility for which it was linked, if that is true, and then a response. I did want to note, thank you. I did want to note there was a couple of sort of interesting commonalities or buckets that I wanted to share with you. I would say for the most part, the issues fell into one of these 5. One, of course, was COVID-19, resurgence and safety. Now remember that these meetings took place between, in September and October. So at the time, we weren't really anticipating where we are now. A lot of the questions were, how do we bring people back safely? So the answers are, sort of the array of all of the things that we had done, our facilities team, our clinicians, to make sure that people can continue to get care safely. The second bucket was sort of a hodgepodge, I guess you will, of facility and equipment questions. Can we get an ultrasound here? Can we fix a sidewalk there? They're, fairly specific to the facility, but again, each one of them has a response. And no surprise, these are things that people see when they think about their community hospitals. The third was kind of a larger bucket, and I lumped them in as sort of equity and social determinants of health. A lot of questions about what H&H does to, continue to advance the larger goals of justice and equity, and how we work with people on sort of a larger basis, not just healthcare. And of course, we are proud and delighted that there are a lot of really great substantive answers to that question. A number of questions about kind of one-off programming issues. Do we have behavioral health here? Do we have mental health services there? Sickle cell showed up. I thought that was interesting. So, for many of those, there's kind of commonalities across the system. For some of them, there are areas where an individual facility may excel or maybe devoting resources. And finally, the fifth bucket is things that, I couldn't find another home for, kind of one-off individual things about, a meal service here, or, a particular employee issue there. That's the overview. They are all there for your availability and perusal, and I'm of course happy to answer any questions.
Thank you so much, Deb. Any questions for Deb?
If I may, Chairman Pagan, this is Bob Nolan. I'd like to thank Deborah Brown, because to the best of my recollection, this is the first time the senior vice president or someone in Deborah's position has actually reported that a report has been completed, questions have been answered, it's on the website. Often what happens is we have our meetings and everybody is told to go look at the website sometime in the summer, and then it tends not to be mentioned again. But I want to thank Deborah for stating this, and this way people who did have questions, they needed answers, if they're on this meeting, certainly will know what those answers are effective today. Thank you so much.
Of course, Mr. Nolan, and I'm sure my predecessors did a great job as well.
Thank you so much. Okay, so due to the virtual, thank you, Deb. Due to virtual meeting setting, the committee and subsidiary reports were emailed to you for submission into the record. Is there any old business to come before this board? Old or new business? Okay, so before I close the meeting, I just want to say, this has been an understatement would be to call the year crazy, right? It has been a very strange year, but all I can say is that I know as chair of the board, we're very proud of all the work done by our staff, clinicals, our doctors, our nurses, everyone, and also board members. I'm so impressed and so glad to be working with all of you, and 2021 is going to be a great year. So let's see how that plays out. So thank you so much. If there's no further business, I declare the meeting adjourned. Thank you so much.
Thank you, Jose.
Thank you.
Happy holidays. Bye.
Thank you.
Thank you, everyone. Be well.
See you next year.
Stay healthy.
Bye. Happy holidays to all.
See you next year.
Same to you. Good night.
Thank you. Felicia, you've done it again.
Not so proud of this one.